Hello and welcome to lecture. My name is Dr. Andrew Craig, and the topic for today is going to be therapeutic modalities. And so we're gonna discuss modalities as they relate to musculoskeletal cases. We'll talk about why you want to use them, when are they indicated, when are they contraindicated, or if it's dangerous to use them. And we'll talk about why one modality might be more appropriate over another. And so if this word is sort of new to you in the rehab world, modalities are essentially um, therapeutic tools that we use, things like therapeutic ultrasound or TENS or IFC, interferential current or shockwave or laser. Um, Acupuncture is a modality. So they're basically tools in our toolbox that we use to help with the recovery process and the rehabilitation process. So they're used generally in conjunction with exercise, lifestyle modifications, and classic rehabilitation procedures that we've discussed throughout the class. So previous iterations of this textbook didn't have any discussion about therapeutic modalities, but I think they've done a really good job with this textbook if you bought a copy of it in chapter 9. So there's a number of charts that are very helpful that I will share a couple with you throughout this lecture as well.
The majority of the content for this lecture was borrowed from these two resources. They're excellent resources about rehab, and they've got lots of information about these types of modalities. If you're interested in learning more, you can explore these resources. The itinerary for today will start with therapeutic ultrasound. What we're going to do is we're going to go through each modality one by one and discuss different items, different facts, and sort of descriptions of each that I want you to understand. So we'll start again with therapeutic ultrasound. Then we'll dive into a couple of different types of electrical modalities. So TENS, IFC, NMES, and microcurrent. You might be familiar with a couple of these. You might be familiar with other types of names, but we'll go through some of the more specifics on it. And then we'll dive into talking about laser and electromagnetic therapies like LED and light emitting diodes and laser technology. So therapeutic modalities is basically technology that's applied through a probe or some type of application wand that imparts a lasting effect on the tissues. This effect will vary depending on which modality you use and what your purpose is. So your intention is very important. What is the purpose for using this therapeutic modality? It's not just this area hurts, so I rub the ultrasound wand on. What are you trying to induce in those tissues? And so there's a number of different reasons why we use therapeutic modalities in rehab. It can be used for anti-inflammation effects. We can look to reduce pain using the gate control theory, which we discussed in week 2 or 3 of this course. We can look to increase sort of the circulation in the blood flow. We can try to push synovial fluid around in case there's some sort of synovitis or some type of inflammatory process happening there. And then we can use other therapies like laser to actually increase mitochondrial turnover of ATP to help the cell to do cellular work. There are a plethora of reasons why we use therapeutic modalities. And once you find out what your goal is, that's what's going to really drive your strategy in terms of what modalities you're using. The number one rule in any sort of treatment, it's even involved in the Hippocratic Oath, is do no harm. Okay. We want to protect our patients at all costs, protect our patients and clients from harm from potential side effects of therapies that we're applying, make sure that they're doing things properly. And therefore, you should follow these steps, especially when you are considering applying some sort of therapeutic modalities. The first of which is always follow your scope of practice and the training that you've been allotted. Don't do anything you're ever uncomfortable with. If you work in a clinical setting and you're asked to do something you haven't been trained on, always ask for help. Okay. You should also follow the manufacturer guidelines and the manufacturer recommendations. A lot of times, different machines will have different settings. and it's individual to each manufacturer. So you need to make sure that you read through the manufacturer novel or novels, the manufacturer guidelines before you start to set up a modality. And then the last thing is you want to stay up to date with the emerging evidence, going through different textbooks, once in a while doing literature searches. If you have a new condition that you're not totally aware of, you can go to the literature and see what modalities are most appropriate and what effects that you would be sort of looking for. Let's begin with therapeutic ultrasound. If you've had any sort of musculoskeletal injuries in the past, you may have had this done in your own experience. So ultrasound, it's a type of sound wave similar to the audible sound that we hear, but it's at a higher frequency. Okay. The human ear hears up to about 20 kilohertz, and that's 20,000 hertz. Ultrasound actually works at it's greater than 20,000 hertz. Okay. And hertz just refers to cycles per second. Okay. So the higher the hertz or the higher the cycles per second, the faster the intervals between. Okay. So if we look at this picture on the bottom right, we've got 1 megahertz on the bottom. Okay. You see how slow the wave is? If we triple that, we get what's called 3 megahertz, and it's a much faster oscillation of the wavelength. So the wavelength is the distance between a peak to peak. So if you look at the 1 megahertz, there's a large distance between these two peaks. And if you look at 3 megahertz, there's a very short distance between these two peaks. So it's a very high frequency wavelength. So much so that therapeutic ultrasound is actually between 1 to 3 megahertz, which is millions of cycles per second. Ultrasound is used for therapeutic purposes. It can also be used for diagnostic purposes, things like any sort of ligament or tendon injuries. You can look at swelling, inflammation. You can also use it. People who are pregnant will go and have ultrasounds for anatomy scans and to tell to sort of check in on the weight and the size of the baby and whatnot. And so for therapeutic ultrasound, it can penetrate through soft tissues anywhere from 1 centimeter to 5 centimeters, depending on the application process and depending on the settings that you use. So how does ultrasound work? It uses these what's called piezoelectric crystals that compress and refract. And this compression and refraction of these crystals actually creates mechanical sound energy that propagates as wave signals, propagates as sound waves. Okay. As the transducer emits that sound wave, okay, if you think about it like this last slide, it's a wave. As it transmits that wave in a linear direction, what happens is those waves are absorbed by the tissues and they can produce a little bit of motion within the molecules. And this is what we call attenuation. So attenuation is that absorption of the ultrasound waves by the tissue. So what happens with therapeutic ultrasound is if you're applying enough ultrasound waves to an area, you get that motion within the molecules. That motion within the molecules creates movement, which creates friction, which will create a thermal effect, or it will increase the tissue temperature. Okay. So if you use ultrasound above a certain threshold, you will get what we call a thermal effect to the tissues because the molecules are moving so fast, they create, there's some heat generation. So we like to break the effects of ultrasound down into sort of two different parcels. You've got the non-thermal effects and you've got the thermal effects. Okay, non-thermal effects happen for both types, whether you have it set to thermal or non-thermal. Non-thermal effects happen at low intensity pulsed application. Okay. That's in contrast to the thermal effects that happen at higher intensity and continuous application. So there's no stopping of the ultrasound signal. Okay? The non-thermal effects obviously the person's not going to experience heat. But what they are going to, what the therapeutic purpose for this is, you're going to increase the permeability of the skin and of the cell membranes of the tissues below it. This can help to accelerate tissue healing. It can actually be used for phonophoresis, which is what we call, which is transdermal drug delivery. So if you have medication that's put over the skin, you can use ultrasound to improve the permeability to that medication, to improve the absorption of that medication. Okay, so those are some of the non-thermal effects. If you use a continuous application of higher intensity ultrasound, what you start to recognize is this thermal effect. So the person will say it's starting to feel warm, there's some heat. Sometimes it can cause a little bit of pain, but it can be very, very comfortable and feel quite therapeutic when you hit the right amount of thermal effect. So it helps to reduce the pain. That increase in tissue temperature also has a number of positive effects. So it increases the local blood flow to the area. It increases the extensibility of collagen. It can increase the enzyme activity, reduce pain and muscle spasms, and it does produce a mild inflammatory response. So if your body's producing a slight inflammation to help the area heal, thermal effects will further facilitate that process. There are also some further applications of ultrasound that have been shown in the literature, and this includes things like, as I mentioned, phonophoresis, where the permeability of the skin is increased, and the ultrasound can actually drive topical medications and gels into the skin. It's also been shown to improve fracture healing, and this is at a lower intensity of ultrasound signal. It's been shown to improve the mobility of fluid within the carpal tunnel. It's been shown to improve reabsorption of calcium deposits. So for calcific tendinopathies or chronic issues, you can use ultrasound to help the reabsorption. It's also been shown to help with improving the healing time for dermal ulcers and accelerate healing of surgical skin incisions. So after surgery, ultrasound at very low intensities can actually help wound healing. Now, as with any treatment, there are some contraindications, both absolute and relative, and I just want you to be aware of a number of these. So you never want to use therapeutic ultrasound over malignant tissue or a space-occupying lesion. You don't want to disrupt the cellular processes within any sort of malignancy. You also don't want to place it over anyone who's pregnant or a possibly pregnant individual. You also don't want to use ultrasound over an infection, over the central nervous system. So any sort of superficial ganglion, the stellate ganglion in the face is one. And if there's any sort of exposed spinal cord matter after a surgical procedure, you wouldn't want to apply ultrasound over the surgical scar just to improve that scar healing time, because you might actually induce significant problems to the central nervous system because of the thermal effects. So that's another contraindication. You also don't want to use therapeutic ultrasound over any sort of prosthetics, whether they're plastic or cemented. You never want to use it over a pacemaker, or over the eyes, or over any sort of reproductive organs in that sense. And a very important one is you don't want to use it over any sort of venous thrombus or thrombophlebitis. I always butcher that word. The reason for this is if there is some sort of buildup of plaque, or if there is a thrombus that is, let's say, in the leg, so a DVT, deep vein thrombosis in the calf. If you use ultrasound and you heat up the area, you might actually dislodge that thrombus, which can lead to significant issues in the lungs or in the brain for a stroke. So you really don't want to be using ultrasound over any sort of arterial issues. If you're using therapeutic ultrasound for for a very acute injury, you want to use non-thermal. Okay. If there's already inflammation there, you don't really want to increase the inflammation. You just want the body to do its job. So if you're going to use therapeutic, or sorry, if you're going to use thermal ultrasound, you're actually going to increase the inflammation and the swelling in the area. So just avoid that. You don't want to use ultrasound over any sort of unclosed epiphyseal plates. So in young individuals, at the ends of their bone, that's where the bone grows. If you use ultrasound, it could disrupt that growth. You only ever want to use low dose ultrasound over a fracture area, and this is actually a very common therapy for people who have severe fractures, or if there was some sort of medically induced fracture, they might use therapeutic ultrasound to sort of facilitate the healing process within the bone. You also don't want to use therapeutic ultrasound over any sort of implants or in any areas of reduced sensation or circulation. This is especially true if you're using thermal settings. And the reason for this is they're not going to be able to give you feedback on what they're feeling. So you might actually do damage to the tissue before they even recognize it. A very common situation in which this occurs is with diabetic retinopathy. Individuals with diabetes can get numbness, tingling in the feet, but they can also get pain in the feet. It's a peripheral neuropathy that they experience. If this is the case and you apply a therapeutic procedure that's supposed to be painful, they won't be able to give you the proper feedback. So you won't know how they are truly experiencing it and if you're doing any sort of damage to the tissue. Okay. The last thing I want to point out is that you should be moving the ultrasound probe throughout the entire treatment. Okay. And this should happen at a consistent pace, about 4 centimeters per second. And this is to prevent any sort of stasis or what we call standing waves. So if you hold the probe in one spot, the exact same tissues are getting exposed to that ultrasound, um, dosage, which can become very problematic. In terms of side effects or adverse events, burns are quite rare, and this can be avoided by using proper settings, taking the proper precautions, not to do it over areas of reduced sensation. You should also not use ice or heat before ultrasound because this can numb the area or cause some sort of sensation deficits. Mimicking what I said on the previous slide, you don't want to leave the probe in one area because this is what we call standing waves, and they can actually cause blood cell clots, and they can cause endothelial damage to the lining of the arteries and the veins. So you don't want to leave the probe in one spot for too long. Probably the most common thing to happen is just when practitioners aren't properly disinfecting their devices, then you get cross-contamination and infection between individuals. So we should always be using a disinfectant of 70% isopropyl to make sure that there's no bacteria that's being passed from one person to another. I didn't put a slide about this in here, but I want to just make sure that you know this. Ultrasound, because it's waves, it needs a medium to transmit those waves from the probe through space to your skin. So we use ultrasound gel, and it's just a lubricating gel that propagates the signal without much loss of that ultrasound wave from the probe to the individual. There's also another number of parameters that you need to consider with ultrasound, okay? Frequency we've touched on, duty cycle, and intensity and dosage. So frequency, this determines the depth of penetration of the ultrasound waves. Increased frequency or higher frequency means that it does not penetrate the soft tissues as deep. Okay, so it's a bit of an inverse relationship. Higher frequency, lower penetration, which is shown on the image on the right. So 3 megahertz only penetrates 1 to 2 centimeters, whereas 1 megahertz actually penetrates up to 5 centimeters. So you can see how this is important. If you're trying to penetrate deep into the glutes, likely the 3 megahertz isn't going to be appropriate. It's not going to penetrate deep enough if you're trying to get to the piriformis, but the 1 megahertz might. Likewise, if you're working on the wrist, you don't need to go 5 centimeters of depth for soft tissue. It's very superficial, the wrist. There's not much muscle mass and other soft tissue there. So probably 3 megahertz will suffice in that situation. The next parameter you need to consider is what we call duty cycle. And this is the difference between continuous or pulsed sound waves. And continuous or 100% continuous provides a thermal effect. So if you're looking for that thermal effect, you're going to go for 100% duty cycle. If you're looking for the non-thermal effects that we discussed, you're going to use a pulsed strategy. And so that usually, each machine's different, but they usually register anywhere from 20 to 50% of continuous versus pulsed. Once you've decided on what your frequency and your duty cycle are going to be, this is when you will decide sort of what's the intensity or the proper dosage. And this comes in the form of watts per centimeter squared. You can use this slide to figure out what sort of intensity and dosage is appropriate, whether you're going to use thermal. We've got that information on this line or this column. And if you're going to use non-thermal, it's on this line as well. For most ultrasound units, this is already pre-programmed, but I've also given you this beautiful little decision matrix that you can print out if you are going to be using ultrasound in your practice. And it just gives you all of the parameters that are appropriate for ultrasounds. And you can start sort of with the tissue impairment or what's bugging the tissue, and you can work through whether you want to use thermal or non-thermal. And then that will tell you, okay, set up the duty cycle to 100% or 20%. And then you have to decide what's the depth of the problem. Do I need to penetrate deep? Do I need to penetrate 5 centimeters, or is it just 1 to 2 centimeters? And then that will tell you whether you should be using 3 or 1 megahertz as your frequency. And then based on your decision of thermal and which type of frequency, that will tell you the ultrasound intensity that should be used. A lot of times, the ultrasound machine, as soon as you turn it on, you'll have to click thermal or 100%, and then you'll choose either your depth of penetration or the frequency, and then it's all set to go. Okay. Now let's use a quick little example to see if you can go through this decision matrix, and you're more than welcome to listen to this case for a moment and then pause the slides and work through it yourself. But let's say you've got a 16-year-old soccer player who came in to see you. They came in with crutches. Their knee is just killing them because they were playing soccer yesterday and they went to make a slide tackle, and you've done a minor assessment and you recognize that their MCL is inflamed. It's not torn, but it's inflamed, and there's a lot of issues there. Okay. Pause right now and go through and see if you come up with what I would say. So if you're going to use ultrasound to complement as rehab, you're going to want to use non-thermal. Okay. This just happened yesterday and there's acute swelling in the knee already. You don't want to increase that swelling. Okay. Therefore, we're going to use non-thermal pathway. We're going to use 20% or 50%, whatever the machine's set up for. And the MCL is a very shallow structure. So we don't need to penetrate tissues very deeply. And so we want to use the setting that's more appropriate for that. So we want to just penetrate maybe 1 to 2 centimeters. So we're going to be using 3 megahertz. Okay. Since we've already got we want non-thermal, so we're going to use 20%. We're going to use 3 megahertz as the frequency. And then the ultrasound machine probably has us set, but we're going to want to use a lower intensity if we have the ability to, just because the patient's likely not going to be able to tolerate a higher intensity if there's that much swelling. Okay, and then we'll plan to do the treatment for say 5 minutes, and we are going to so we're going to do it for 5 minutes, and we're going to do it in 2 times the ERA, and we'll talk about what the ERA is. I think I skipped over a slide there. Okay, apologies, I skipped over this slide. But to backtrack, The ERA is the effective radiating area. Okay, the effective radiating area is your treatment zone. So what's the area in which you're planning to treat the individual for? So um, the ERA should be a minimum 1.5 times, or sorry, the area to be treated should be minimum 1.5 times the ERA and the maximum 4 times. Okay, so if this sort of grayish circle is the ERA, we need to be 1.5 times bigger in order to keep that continuous motion up so we don't get stasis in the tissues below. Okay. Now you can do circles with the probe, you can do zigzags, you can do figure eights, you can get creative and spell letters, whatever you need to do, but you kind of want to have consistent motion so that the tissues are getting the same amount of dosage, but it's just being done in a way that it's not causing any static ultrasound to be applied. Okay. You do need to remember to ask for informed consent, and this will be dependent on what the Ontario Kinesiology Association says. For us, we have to talk about the chance of, as a chiropractor, I need to discuss the chance of potential burns or skin irritation. It's going to cause a little bit of heat production, some potential swelling that may sort of be aggravated, and there might be a little bit of increased pain with the ultrasound. So I always just say, make sure that you're keeping an open line of communication with me as we're applying this treatment. I want to know how you're feeling, okay? And then I always make sure I document it. So there's always a written documentation that the individual can read, and I need them to sign, and then I have them verbally also agree, yes, I am opting into this therapy. Okay, let's move on to electrical stimulation. Okay, this therapy has come a long way over the years. It's a fantastic tool for modulating pain. It's great for activating muscles that might be denervated, lost their innervation from nerves, or that might be negatively affected from a neurological standpoint. So there's a number of different strategies we can use with electrical stim, and we'll go through a few of them. This treatment involves the application of electrical current through electrodes to the body, and we're looking for a therapeutic benefit. Okay. Electricity flows from positive to negative, so it's important to place the electrodes strategically on the body. Okay. You might find some fancy electrodes that have both the positive and the negative in the same sticky pad. They're usually massive and go over a huge area. Most clinics that I've worked with and worked at, they have multiple pads. Typically the three types of nerve bundles that respond to different thresholds of electrical current are sensory, motor, and pain. Okay. Sensory nerves respond really well to short, low amplitude pulses. The motor nerves, they respond more to medium duration and medium amplitude pulses, whereas the pain pathways are activated through high duration, high amplitude pulses. Okay. And you'll see this graph in the bottom right. We're going to discuss it in a few over the next few slides. Since you can activate any one or combination of these types of nerves, it's nice because you can apply certain forms of electrical stimulation to selectively activate these pathways depending on what your intention is with your treatment. When you turn on the machine, the electricity will flow through the machine, through the electrodes. It's attached to the skin, so it goes to the skin, and then it affects the local peripheral nerves. Okay. When that electricity hits the peripheral nerve, it sends a sensory signal towards the central nervous system. Okay. So it activates the sensory nerves that go towards the central nervous system. It also can activate the motor nerves or the efferent nerves, and it can send signal the opposite direction to the muscle, and it can stimulate a muscle twitch. Okay. So this is how you produce that sensory signal towards the central nervous system and motor signal towards the periphery. The reason you would do this, so that the sensory signal is typically to induce sort of pain killing therapeutic response. Okay, so you're trying to reduce their negative sensory experience. The motor, on the other hand, is to try to induce either some muscle twitching or maybe some increased in blood flow to the muscles, that sort of thing. So you're trying to induce basically different effects, and that's why it's important to know what you're trying to achieve. A lot of times when someone's in excessive pain, I'll use these pads if they're in, say, 10 out of 10 pain, and I'll say what we're looking for is, I want this to be comfortable, I want to feel intense, but I don't want you to feel any sort of twitching. No twitching. Okay, that's how we're going to achieve that pain control effect. On the other hand, if it's a muscle strain and pain isn't the main problem, we are actually trying to regenerate the tissues or try to get a better muscle pump, I'll say, we're looking for that muscle to twitch. I want you to tell me, or I can often see when that muscle starts to twitch. So again, you do have these sort of three primary effects or goals of electrical stimulation. The first of which is pain modulation, and this is done through the gate control theory of pain, which we went through in detail in a previous webinar. Endorphin release. So we get basically release of endogenous opioids or painkillers that our bodies make naturally. And then we can also take advantage of the pain spasm pain cycle, which is another pain modulation technique. If we're looking to induce effects at the muscles, what we're looking to do is to either strengthen, re-educate the muscles in the nervous system. We can reduce swelling through improving the muscle pump by contracting the muscle repeatedly. We can do that at different frequencies as we need. It can help to reduce any sort of muscle spasms for people who have incredibly tight muscles and might be on antispasmodic medication and Robaxacet type of medications. And then we can modulate their pain as well, which goes back to that sensory nerve stimulation. And the last thing we can do is facilitate tissue healing. And this happens in terms of reducing the formation of inflammation with that muscle twitch. The type of stimulation to a nerve is dependent on two primary variables. You've got the current strength or amplitude, which is typically adjustable on the machine. It's usually a dial that goes up or down. Sometimes it's just associated with a number from 0 to 50. The other variable that we look at is the pulse duration and width, which is adjustable for tens, but it's not actually adjustable for interferential current or IFC. Okay. The pulse duration and width, it's intrinsic to the machine, and it's usually anywhere from 200 to 400 microseconds. Whereas that's for IFC, and for tens, it's adjustable, and it's anywhere from 40 to 300 microseconds. These are the various types of electrical stimulation that we're going to discuss. We'll talk about transcutaneous electrical nerve stimulation, which is TENS, interferential current, which is IFC, neuromuscular electrical stimulation, which is NMES, and microcurrent, which might be a new concept to you. Okay, so TENS, or transcutaneous electrical nerve stimulation. This uses what's called a pulsed biphasic current waveform. It can target sensory, motor, or nociceptive pain fibers. So biphasic means it's either always on or off. Okay, so you've got positive polarity and negative polarity. That's why it's biphasic. But if you contrast that graph to interferential current, which has a slowly progressive change in the polarity, right? So it slowly increases and then decreases, and then increases negatively, then decreases negatively. Whereas tens is just on or not on. It's absolute numbers. Okay. This graph I want you to get quite familiar with. So we've got the pulse duration. okay, or the pulse width in microseconds. And then we've got the current strength in I believe that's microamps. Okay. The red line represents the sensory fibers. The purple line represents the motor fibers, and the green line represents the painful fibers. Okay, we're going to ignore these two for now. Tens, if you remember, I said tens actually exists between 40 to 300 microseconds of pulse duration. Okay, so I've indicated that in the black square here. So with tens current, we can stimulate the sensory fibers, we can stimulate the motor fibers, or we can stimulate the painful fibers. And we can do this by, let's say it's set to 100 microseconds is the pulse duration. If we increase the current strength, so we increase the dial, we will typically get activation of those sensory fibers first. So the individual will start to feel something. They often say it feels like ants crawling, or it feels like little pinches. And then if you keep increasing that current, you will get activation of those motor fibers that are associated with the underlying nerve. Okay, so typically the person will say, I start to feel the tingling, and then you keep turning it up, and then you start to get a motor twitch, and you start to see the muscle twitching. If you continue to increase that current strength, you will activate a painful stimulus, which is very uncomfortable. Okay, so it's kind of a fine line how you activate these three different types of nerve fibers using tens. The same is true for interferential current. Okay, but what we see is it uses a different pulse width. Okay, so it's shifted slightly to the right. If we go back a slide to tens and then forward one slide to IFC, we see that we're using sort of different microseconds for the pulse duration. And so that means we are probably going to be using different amounts of current, right? You have to use, if you're using tens and you're at, say, 40 microseconds, you have to use a very high current to activate those motor tissues. If you're looking to activate the motor tissues and maybe you want to use less current to do so, you might be smarter to use interferential current because you need a lot less current to actually activate those tissues. So the difference between the two waveforms technically is that interferential current uses alternating current, and that's this typical sinusoidal wave you see here, whereas the tens uses that biphasic on or off, all or nothing sort of signal. Now, neuromuscular electrical stimulation uses both waveforms, okay? And it's primarily used to achieve pure motor twitch responses, okay? NMES is often used for improving strength production. So it's used a lot in weight training. It's one of these things that kind of comes and goes with the bodybuilding sort of community. NMES you can use a lot with rehab. So let's say, for example, a post ACL reconstruction, you might use NMES to improve the optimized muscle contractions for the quadriceps and whatnot. So NMES is a combination of TENS and IFC. Microcurrent is quite a bit different, okay? So microcurrent, where does it exist on this graph? It exists in what we call a subsensory environment, okay? You apply the same thing. You put two pads on the body with a positive and a negative end, but the pulse duration is so low that it actually is lower than your sensory fibers will pick up. So you won't feel anything with microcurrents. Okay. It utilizes a pulsed current similar to tens, but it doesn't actually activate any sort of sensory fibers. If you're activating sensory fibers with microcurrent, you're doing microcurrent wrong. Now, It's quite interesting. The microcurrent works by restoring the normal polarity of cells. So you've got a natural positive negative polarity across the cellular membrane. Microcurrent acts at the cellular level to normalize that. It isn't as well established within the published literature. Um, but the proposed function for microcurrent is to reduce pain, reduce cellular edema. It normalizes the cellular permeability across the membrane, and it facilitates healing. So a lot of people will use this for things like fracture healing, or if there are significant scar tissue in the area, people will use microcurrent to try to normalize the direction in which that connective tissue lays down properly. I know this is a big thing for scar healing for cesarean scars or C-sections. People will use microcurrent for this purpose. And so I think there's going to be a lot of interesting research pop up over the next few years. We just don't have the best research to prove its effectiveness or to refute its effectiveness. So what are the contraindications to using electrical stimulation? And this is especially true for all of these forms. You should never use it over any sort of implant to the heart. So cardiac pacemakers, defibrillators, or anybody who has a improper arrhythmia in the heart. Remember, the heart is it has an electrical output. So if you're going to put electrical current over top of that, you might actually disrupt that natural electrical output. You also don't want to place it over large arteries like the carotid sinus. You don't want to put it in areas where there might be a clot formation. You don't want to use electrical stimulation over anybody who's pregnant, and you don't want to use it over any sort of active bleeds. Again, other precautions that you need to consider are any type of cardiac disease, anybody who has impaired sensation. So again, diabetic neuropathy might be they might be have challenges to tell you what's wrong or how they're feeling. You shouldn't use it over malignant tumors because you don't want to negatively impact the growth factor of those tumors. And you don't want to use it on areas where there's any sort of open skin, okay, or open wounds. The reason for this is there is altered impedance over those areas, and you've got altered sensation. So the person's sensory experience might not actually equate to the damage that you're doing within that area. These are some other areas that you need to avoid with electrical stimulation. So transcranial, so you don't want to do it across the brain for obvious reasons. You really shouldn't be using it over reproductive organs or over the eyes. I mean, a lot of these are relative contraindications, like the lower abdomen, the chest. You need to use your clinical judgment for those, but I would say the other ones are probably rather absolute contraindications. So how does electrical stimulation help with pain control? I've touched on this briefly, but we're looking at controlling pain through the gate control mechanism of pain. We can get immediate and short-term pain relief, and this is done at the level sort of the thalamus and at the level of the spinal cord. If you need a review on how the gate control theory works, please refer back to our lecture on pain and pain mechanisms. The other pain control mechanisms of electric stimulation is endorphin and enkephalin release. This is endogenous opioids that are produced and released in the body. And so it promotes the release of these hormones, which are natural painkillers. Okay. When these hormones are being released, it will last for about 4 to 5 hours. And all you really need is about a 20 to 30 minute stimulation session. And the reason it lasts for 4 to 5 hours is just because of the half-life of endogenous opioids they'll degrade over that time. Here's a disclaimer that I like to put out here. make sure that you're following all the safety protocol. That means the safety protocol in the clinic space that you're working, means the safety protocol of your association. You got to make sure that these things all align. Okay. Don't do anything that you're not comfortable with, and only use things that you're trained on. If you're not trained, seek training in that endeavor. Okay. Before you apply any therapeutic modality, make sure you're considering what's the purpose? Why are you doing it? You're not just adding treatments to the individual, there needs to be intent. Are there any contraindications that you need to consider? And what are going to be the best parameters? You really must consider the safety of the individual and the therapeutic intent that you are hoping to administer to the person. So here are some techniques for applying electrical stimulation. You want to sort of, if there is a lot of hair over the area, you want to trim it. You don't want to shave, because what shaving can do is cause little micro cuts, and it can change the impedance, and it can also change the sensation in the area. Before you apply any sort of modality, make sure it's turned off. You can cause a really big shock to somebody if it's not turned off and you apply a pad and it's already on. Then you want to connect them to the then you want to connect the electrodes to the unit. And you're welcome to read the rest of those sort of application techniques. The last therapy I want to discuss is phototherapy and laser. Okay, this is an area that has probably the most literature support that I've seen. It's probably one of the most effective treatment modalities that we provide at our clinic, and it includes electromagnetic radiation. Electromagnetic radiation is comprised of electric and magnetic fields that are oriented perpendicular to each other. Okay, so they're perpendicular and they vary over time. These waveforms, they can propagate without the need for any medium. And so they can go through the air, they can go through, they can penetrate through skin, through soft tissues, and they can impart an effect at a depth that you so choose based on the parameters that you set. It's categorized and described in terms of its wavelength and its frequency. Okay, so wavelength is the distance between the peaks. Okay, so that's your wavelength. The frequency is how many cycles per second, and then the amplitude is how big is that wavelength. When we look at a portion of the electromagnetic spectrum, which is on the slide here, we can differentiate between different types of light. So you've got visible light. Okay, at higher frequencies, you've got UV or ultraviolet, you've got X-rays, and you've got gamma rays. Gamma rays are ionizing radiation. This can be used to break down molecular bonds to form ions, and this can be used at very low dosages for imaging, or high doses to sort of destroy tissue, which is typical for unfortunate cancer treatments and whatnot. So that's on the higher end of the spectrum. You've also got, just lower than visual light, is infrared, microwaves, radio waves, which we listen to all day long as well. And so above visible is what we call ionizing radiation, because it can break down those molecular bonds. Below sort of the ultraviolet threshold, we've got non-ionizing radiation. Okay, and visible light is anywhere between, I believe, 600 to 700 nanometers. Near infrared is 700 to like 905 nanometers. And so what is laser? Laser is actually an acronym. I'm not sure if you knew that, but it stands for light amplification by stimulated emissions of radiation. Okay, it's a mouthful, and that's why we short form it to laser. When we use laser or LED or any other type of phototherapy, we are exposing someone to specific wavelengths of the electromagnetic spectrum for the purposes of for therapeutic purposes. Okay, Most commonly, we see low-level laser therapy, or LLLT, which uses typically one frequency of light. It travels in what we call a coherent matter. So coherent wavelengths are shown on the bottom of the slide here. So they travel in sync with each other, and they travel in one direction. Okay, so they don't have a divergent path. So that's why lasers look very much like this. Hopefully, you can see my cursor on the screen, because they're in this coherent manner and it's all one wavelength. Okay. If you look at the wavelength of light that laser uses, this graph in the top right kind of indicates that it only uses a single specific wavelength. LED, or light emitting diodes, on the other hand, they use an array of different frequencies, but it's centered around one area. Okay, so 630 nanometers in this case, and 632 for the laser. LED, because it has this array of different frequencies, it usually has this divergent path, or it always has this divergent path, because it's non-coherent and it uses an array of different frequencies. So what I want you to know about the difference here, I want you to know that laser therapy, it uses a single frequency. It travels in a coherent matter, which means that it's in sync, and it's directional, meaning that it does not diverge from a single path. Okay. LED, on the other hand, or light emitting diodes, these use an array of frequencies around, one common frequency. It's not non-coherent, and you have a divergent path in the light. Okay. Phototherapy can be used to facilitate healing. It also can be absorbed by the mitochondria. So you've got what's called intracellular chromophores, which can absorb the protons, or the light energy, and they can convert it and facilitate the development and release of ATP. Okay. So one of the biggest, most fondest effects of laser is that promotion of ATP production. It also promotes collagen production. It modulates and regulates inflammatory processes within the cell. It can promote vasodilation. It can reduce pain and swelling. It can alter sort of the nerve conduction velocity and regeneration. And so a lot of what the laser does goes back to the cellular cascade that's involved in the Krebs cycle. And I'm sure you've learned the Krebs cycle. I'm not going to force you to learn it because it's not really clinically applicable in this case. Just know that it helps within the cellular cascade of the Krebs cycle. When is laser contraindicated? Typically, you should never use it over somebody's eyes. You should never use it over a malignant mass, or during the 4 to 6 months following any sort of radiation therapy. It also shouldn't be used over top of active bleeds or DVTs, and you should never use it over top of organs that might have an endocrine function, like the thyroid, or over top of the genitals. Okay. Here are another number of precautions that you need to consider when using laser or light therapy. Now, adverse events or side effects, I don't often see, as long as you're using the proper eyewear. You need to use specific glasses that block out that frequency of light. As long as you use those, the person's eyes will be totally fine. They might feel some sort of warming or burning sensation. There might be a little bit of redness or a skin rash afterwards as well. So those are all very typical side effects, but they're often incredibly mild. I've never had a severe reaction to laser, knock on wood. And again, just make sure that you're protecting your patient at all times. Remember, that's part of our role, is to follow what we know, follow our training, follow what the manufacturers are recommending, and try to stay up to date with the emerging literature. One unique thing that you must do with laser and light therapy is use the goggles, and it's always good to put a sign on the door so nobody walks in and gets exposed to that as well. Now, there are 5 different classes of laser, and it's all based on the power output. Uh, class 1 to 3A are very sort of lower dosage, lower power lasers. They are all licensed by Health Canada. And class 3B lasers, that's just the classification. I'm not sure why it's called that, for the type of laser that we would use in a therapeutic perspective. Okay. And you can see it's a wide range. If you're above 5 megawatts, you can go all the way up to 500 and still be classified under a 3B laser. The higher the power, generally, the more expensive the laser unit and the more applicability. Once you get over 500 megawatts, then you're into the class 4. This is sort of surgical type of lasers, and typically you need more training and more advanced degrees to be able to use the class 4 lasers. Most devices don't allow you to change a lot of these settings, but some of the fancier machines will allow you to. So you can look at the energy density. Most units will just have pre-programmed settings for each condition. So they'll have like soft tissue healing, one for neuropathy, acute inflammation, chronic inflammation, and arthritis. And the energy density will just change based on what you select from the unit. When you are documenting your laser application, it's very important to put what type of diode you used. If you used laser, if you used LED, if you used a combination of the two. You should also document what wavelength, what the power was, what was the body region, and often how many times. Because, for example, one of the laser diodes or one of the laser probes that we use only has a very small area, maybe about an inch in circumference. And so if you're doing an area like, say, the knee with laser, I might put 4 points over the knee joint, 2 medial, 2 lateral, and 1 inferior to the patellar tendon, just so that I know exactly where I put that dye or the application wand in that treatment session. Thank you for listening. I know this is a little different than most of our lectures. I hope you learned a few things about modalities. And if you have any questions, please feel free to speak up during our next webinar. I hope everybody had, well, at the time I'm recording this, we just finished reading week. And so I hope everybody had a fantastic reading week. I went on a big hike with our friend from the lab here, Ryan Foley, last year, and I just thought I'd put this picture up. Anyway, thank you for listening. I hope you have a fantastic day, and I will see you during our next lecture.